Endodermal derivatives. It is understood that endoderm is the first germ layer to develop from the epiblast during gastrulation, and endoderm is, as the name is suggesting, on the inner side. It is going to give us the epithelium of gut tube, but from the gut tube, as we understand, there is a foregut, midgut, and hindgut. From the foregut develops the respiratory tube. So even the respiratory tube, especially the epithelium, and since epithelium give glands, so epithelium and glands of gut tube and the respiratory tube are from endoderm. On the other hand, the hindgut will contribute to the lower portion of genitourinary system. When you say lower portion of genitourinary system, actually you are talking about what is called as urogenital sinus, and that urogenital sinus is from endoderm, giving us derivatives like urinary bladder and urethra and lower vagina. So the epithelium of urinary bladder, urethra, or lower vagina is also from the endoderm. Not only epithelium but also glands. So this is some basic idea which we are having, and then we can proceed further with some diagrams before we draw our own diagram. Now in this diagram you can see we are looking at the foregut region here, initial part, and then we are also having the next part which is the midgut here, and then we can also look at the terminal part which will be the hindgut region here. So as we are marking, you can mention this is the region of the foregut where we see structures like esophagus or stomach or proximal duodenum will develop foregut. But if we are focusing upon this area, then it is the midgut region where you have distal part of the duodenum and most of the small intestine, then till the right 2/3 of transverse colon, it is midgut. And after that, when you are focusing upon this region, this is the hindgut, which is left 1/3 of transverse colon and descending colon, sigmoid, rectum, etc. So that is hindgut. As we are marking, this is the hindgut region. Here we have the midgut region, and this one is the foregut region. One septum will be developing here in the foregut region, and we'll find that foregut gives us anteriorly the respiratory system, whereas posteriorly we have the gut system. The septum is called tracheoesophageal septum because in front will be trachea and behind that will be esophagus. We'll draw that in our diagram, and sometime if tracheoesophageal septum has a deficiency, you can have tracheoesophageal fistula, which can be dangerous, leading to aspiration in the lungs. Similarly, in the hindgut, we'll have urorectal septum, which is dividing the urinary system anteriorly, that is urogenital sinus anteriorly, and posteriorly it will the rectum. Hence, the name is urorectal septum because in front is urogenital sinus and behind is rectum. This also will draw in our diagram, and of course, if there is a deficiency in the urorectal septum, you will find some of the fecal matter entering the urine. There can be fistula between rectum and urinary bladder or urethra because the septum is not properly developing. Also, you see midgut diverticulum, which is endodermal, the Vitelline duct, and hindgut diverticulum, which is allantois, which is endodermal. Both of them become content of the umbilical cord, and normally they degenerate. But what will happen if this Vitelline duct, which is a content of the umbilical cord, do not degenerate? It can lead to Meckel's anomalies like Meckel fistula, baby born with fecal matter at umbilicus. so Meckel's anomalies due to persistent vital intestinal duct. On the other hand, what if the allantois, which normally is obliterated to form urachus, what if urachus was not obliterated and there was some fistula, then you'll have a baby born with urine at umbilicus. So baby born with urine at umbilicus because of the persistent lumen in the allantois, or you can say better term is urachus, urachal fistula. So we'll be seeing that they are normally a content of umbilical cord, but they should be obliterated normally. Now in the foregut lateral wall you have pharyngeal pouches, and these pharyngeal pouches can give you glandular tissue of thymus parathyroid gland. So they are parenchyma developing in pharyngeal pouches. These are pharyngeal pouches. They give thymus or parathyroid parenchyma, means glandular tissue. All of these are MCQs actually. If you're talking about liver and pancreas developing at the junction of foregut and midgut, the liver and pancreas, they are also from endoderm. Endoderm will give the parenchyma, the glandular tissue, and it is from mostly contribution by foregut. Foregut forms liver and pancreas, but at the junction of foregut and midgut. As you can see, this black color we have told is foregut, and this blue color we have told is midgut. So liver and pancreas develop at the junction of foregut and midgut. With that idea, let us draw our own diagram. So we are telling this is the gut tube, and gut tube is having the epithelium, not only epithelium but also the glands, because glands develop from epithelium only. So they are from endoderm, and this gut tube will have certain parts, like there is a foregut, there is this midgut, and then the hindgut. Now in the foregut we'll find there is a septum which is called as tracheoesophageal septum. It is called tracheoesophageal septum because in front develops not only trachea but also the bronchus and the lungs. So trachea, bronchus and lungs, they are all from endoderm of the foregut, and not only their epithelium but also glands. So epithelium and glands of the trachea or bronchus or lungs means respiratory tube, whereas posteriorly it will be the foregut part, that is esophagus. That is why it is called tracheoesophageal septum. So in front we see trachea is developing, behind is developing esophagus. What if there is a deficiency? Then there can be tracheoesophageal fistula, baby having milk in the lungs. But why the baby is having milk in the lungs? Aspiration pneumonitis. Mother was feeding milk to the baby, and milk will come to esophagus, but from esophagus it will enter the trachea, from trachea it will enter the lungs. So milk in the lungs, and that is aspiration pneumonitis. It is dangerous. So if you find that mother gives any clinical feature suggestive of tracheoesophageal fistula, you should immediately stop feeding milk and take care of that problem. Now in the hindgut, basically the terminal part of hindgut, you will see there is a cloaca region, and in the cloaca region one septum is developing, that is called as the urorectal septum. Now why it is called urorectal septum? Because in front is urogenital sinus and behind is rectum. That is why the name is given. So terminal part of the hindgut, which is called as cloaca region, one septum is developing, which is called as urorectal septum, separating urogenital sinus anterior and rectum posterior. Rectum will open as anal canal. The rectum opens as anal canal, whereas the urogenital sinus will have two openings, like if it is a female, urethra and the vagina. So basically urogenital sinus, you can remember three derivatives: not only urinary bladder and urethra, not only urinary bladder and urethra, but also lower vagina. They are all from endoderm, of the hindgut or urorectal sinus. So in front of urorectal septum, we have urorectal sinus, which is of course from the endoderm of the hindgut. And the three derivatives of urorectal sinus, endodermal urorectal sinus, are urinary bladder and the urethra and the lower vagina. So they are all lined by endodermal epithelium and glands. Comes as a question. Now we have seen that there was this lateral wall of the pharynx having pharyngeal pouches. The lateral wall of pharynx, right and left side, will have pharyngeal pouches, and pharyngeal pouches giving us glands like thymus gland or parathyroid gland, and their parenchyma or glandular tissue is also from endoderm. At the junction of foregut and midgut, we had liver and pancreas. Though liver and pancreas, they develop at the junction of foregut and midgut, but they are chiefly contributed by foregut and their parenchymal tissue, that is glandular tissue. Now we also know that midgut will have a diverticulum which will enter the umbilical cord. This is the umbilical cord, and inside the umbilical cord will have this vitellointestinal duct, which is midgut diverticulum, endodermal in origin, and normally it should be obliterated. If it is not obliterated, we can have Meckel's fistula, and Meckel's fistula means the baby may have fecal matter coming at umbilicus from the midgut region. Now that is about the vitellointestinal duct. What about the urorectal sinus giving urinary bladder? And it is having one attachment, allantois. Normally allantois is obliterated to form urachus, but sometimes this urachus can have a patent lumen, which is called as allantoic fistula. So if you have urachal fistula, is a better term. If you have urachal fistula, you might find the baby is born with urine at the umbilicus. So there was a baby born with urine at the umbilicus, because here we are having what is called as the urachal fistula. This is urachal fistula, and that was the Meckel's fistula. Meckel's is basically for the midgut, and if you are telling it is the urachal fistula, then it is for the hindgut, but then both are endodermal in origin. So here not only we have seen the derivatives of endoderm, but also some of the anomalies which will be discussed in detail in the abdomen region and pelvis perineum region.